Good morning, everyone. You're welcome to today's webinar titled Opioid Exposure in Pregnancy and Neonatal Period, a Harm Reduction Approach. Apologies again for the slight delay in starting, but we will get right into it. My name is Tammy Akintilebo. I'm the coordinator for the Perinatal and Infant Health Program here at the Saskatchewan Prevention Institute. First of all, I'd like to acknowledge that we are on Treaty 6 territory and the homeland of the Métis people. Presenting today's webinar is Dr. Kali Gartner and Dr. Mali Brindamore. But before I hand over to them, I'll just briefly highlight what we do within the Perinatal and Infant Health Program for those who may not be aware or who are just joining our webinar for the first time. So the Perinatal and Infant Health Program of the Saskatchewan Prevention Institute seeks to provide information and create awareness on topics and health issues relating to preconception health, pregnancy, and postnatal health. And our primary stakeholders are health and allied health professionals as well as service providers. We also provide our information to the general public, and we do this through primary prevention strategies. Some of the topics that we cover include things like gestational diabetes, maternal mental health, maternal and child environmental health, substance use, domestic violence, and also topics in early infancy, such as breastfeeding, vaccination, and safe sleep infant practices. Um, I will not waste so much time again. I'll just go ahead and introduce today's speaker. But just to mention, feel free to use the chat box to type in your questions or comments while the presentation is going on, and the presenters will be happy to respond at the end of today's webinar. So I would like to introduce the speakers for today. First is Dr. Kali Gartner. Dr. Kali Gartner is a family physician working at the Saskatoon Community Clinic and Westside Clinic in an interdisciplinary team-based care setting. Her practice includes caring for people during pregnancy, in labor and birth, and caring for families postpartum and beyond. She completed her enhanced clinical skills at the University of British Columbia Department of Family Medicine in Addictions Medicine and HIV care at the St. Paul's Immunodeficiency Clinic in Vancouver, BC. She previously practiced in Vancouver at Sheway, a pregnancy outreach program for women with substance use in pregnancy in the downtown east side, as well as the Maxine Wright Health Center in Surrey, BC, along with providing family practice maternity care at the BC's Women's Hospital and Surrey Memorial Hospital. Our second presenter for today is Dr. Mali Brindamore. She's a general pediatrician with a special interest in global health, refugee, and indigenous health. She has the immense privilege of looking after newborns living in Sanctum 1.5, a transitional and supportive home for mothers and their infants facing challenges such as homelessness, addictions, and HIV. She also provides outreach pediatric clinics to the Métis and Dene communities of Île-à-Crosse, La Loche, and Stony Rapids in northern Saskatchewan. She serves on the board of the North American Society of Refugee Health Care Providers and is the president of the Canadian Pediatric Society Global Child and Youth Health Section. With the Saskatoon Refugee Health Collaborative, she's co-founded the Refugee Engagement and Community Health clinic called REACH, where she provides regular pediatric care to refugee children. So without much delay, I'll hand over to our presenters for today as we get into our presentation. So if you can unmute your mics and your webcam.
Good morning, everybody. I hope you can see and hear me. You okay to proceed?
Hi, can everybody hear me? It looks like it. So without hearing any complaint, I will start. Sorry for the delay once again. Oh, I'm hearing that people can't hear me. Is this better?
I can hear you, Molly.
Okay, I just don't know how to fix this situation, so I think unfortunately we'll have to continue like this. But thank you, Tammy, for the introduction. It's really a pleasure to be here, and I'm certainly very honored to do this talk with my friend and colleague, Dr. Gardner. And so during this talk, we will talk about opioid use and related harm in Saskatchewan and review our current context. While we're doing this, we'll also discuss and reflect on principles of care for people who use opioids in pregnancy, including details on trauma-informed care, person and family-centered care, and harm reduction, so that you can incorporate some of these notions into your respective practices. We'll also talk a little bit about stigma and trauma and how that can contribute to poorer health outcome in people who use drugs as well as their infants. And then towards the end of the talk, we'll review the current evidence for holistic treatment of substance use disorder in pregnancy as well as in the newborn period. And we will touch on the use of the eat, sleep, console approach, as well as the approach that we use at Sanctum 1.5 in treating opioid use disorders. Next slide, Tammy, please. Just the slide before, please. Yes, some definitions. So while we're doing this talk, Dr. Gardner and I are also learners, and so we're committed to growing our trauma-informed and woman-centered approach. And so we will let you know what we know, but also that we're committed to learning more from you as we go. And we're doing this while understanding the history and ongoing colonization and impact on the health of the individual of Indigenous people that all of this has. And so during this talk, we will talk a lot about neonatal abstinence syndrome as well as its cousin, neonatal opioid withdrawal syndrome. So when we talk about that, NAS is more of a general term. It describes all of the newborns who are at risk for substance withdrawal. Those substances can be opioid, nicotine, SSRIs, crystal meth, or any others, while NOWS, or neonatal opioid withdrawal syndrome, is more specific and pertains only to opioids. So while we'll use these two terms interchangeably, however, we mostly talk about NOWS in this presentation. When we talk about opioid agonist therapy, we refer to the pharmacotherapy treatment like methadone or buprenorphine that's prescribed by healthcare providers for treatment of opioid disorders. And then Dr. Gardner and I also wanted to say that when we use the term women or moms, we understand that there are diverse identities in people who give birth, so we will use these terms interchangeably as well. And Tammy, if you could go to the next slide, and I will give the mic off to Dr. Gardner.
All right, thanks everybody. So we're just really briefly going to touch on looking at our context of opioid use-related harms in Saskatchewan. So just wanted to, I'm sure you're all aware, just touch on that, we're experiencing really high rates of opiate use-related overdose deaths, and this is in Saskatchewan as well as throughout Canada, and especially in 2020. So those are just the preliminary data for 2020 there for Saskatchewan, but you can see that there's been calls from the community for attention regarding overdose deaths in Saskatchewan. We now have almost one death a day, and there's still a few months left of the year to count. And overdose deaths are really just the tip of the iceberg, because there's also overdoses that don't result in death, but other injuries, and there's a whole lot of other opiate and substance use related harms. And I guess just to kind of highlight that most of the substance use related harms are really more understood now as the result of criminalization of substance use and not related to substance use in and of itself. So, this is linked to the increasingly toxic drug supply that's in Canada and around North America and other parts of the world, stigma towards people who use drugs, criminalization of drug use. So I guess we'll just kind of leave it at that, but just to highlight that it's, there's a lot of complexity. And then when we're thinking about infants and pregnancy, there's some data from Canada shown here that looked at the rates of neonatal abstinence syndrome for single live births in Canada. And you can just basically see that over time, there's increasing numbers of infants born and diagnosed with NAS. And this is seen in all segments of the population, but more sharply rising in people who were classified in the low socioeconomic status quintile, women who were younger when they gave birth, and people who lived in rural areas. And this study also looked at maternal morbidity and infant morbidity and mortality, and just highlighted how pretty much on every indicator, women who had infants diagnosed with NAS had higher rates of other comorbidities. And basically the conclusions were just that we need more wraparound mother and family centered care programs. And if I back to the care.
Yes, we wanted to touch base on a bit on newborn apprehension and birth alerts. So as I'm sure most of you are familiar with, birth alerts are a practice that's allowing social workers or healthcare practitioners to notify protection agencies if they feel that there is a risk to the newborn or the unborn baby for any reasons. So oftentimes, parents or caregivers are not informed that those alerts were made. They're often tied to substance use disorders, mental health challenges, but most importantly, poverty and the social determinants of health. And so it's important to know that apprehensions does not always ensue, but birth alerts can be in part the cause of significant trauma associated to medical care for families who are already oppressed in other and in multitude of ways. So, of course, if apprehensions do happen, the disruptions in care associated to these can lead to severe challenges for both infant and parents, and often the prolongation of the intergenerational trauma cycle. Because often the baby's moms were also apprehended at birth or have a history of involvement in the foster care system or residential schools. Let's also remember that 70% of kids in the foster care system in Saskatchewan are Indigenous. If we look at the Canadian average, it's more around 40%. So we're not really doing well when we compare ourselves to the rest of Canada. And so I don't need to tell you that probably, but apprehensions at birth impact the mom and infant's bonding, attachment, regulation, and separation between parents and children is one of the most traumatizing events in a child's life and can have lifelong consequences. We'll come back to these traumatizing events a bit later in the presentation, and we'll outline how they can affect lifelong physical and mental health. So if you look at these numbers, they come from a Freedom of Information request to the Ministry of Social Services in 2018. It's difficult to find data on birth alerts otherwise. They're high for such a small province. And when you look at those, remember that this practice of birth alerts and apprehension in general is regularly denounced by Indigenous leaders, and notably with a call for justice, calling for an end to birth alerts by the National Inquiry on Missing and Murdered Indigenous Women and Girls in the spring of 2019. There are things that can be done about that. Notably, BC, a few months after this report came out, put an immediate ban to birth alert back in September 2019. There's still work to do here about that.
principles of care for people who use opiates in pregnancy, including trauma-informed care, harm reduction, and person and family-centered care, and hopefully a few tidbits that you might be able to include in your practice or enhance going forward. So first of all, just to touch on universal screening. So screening for substance use in pregnancy is recommended by our Society of Obstetrics and Gynecology Canada guidelines. I think it's just some general things that to consider, like asking permission and explaining why we are wanting to screen for substance use. And a person might not feel comfortable sharing this in the first visit, and is recognizing that's okay, but try to be open-ended and non-judgmental and making it more of a conversation, focusing on someone's strengths and just kind of building rapport and relationship. And we can use, like, there's a lot of different tools we can use, like motivational interviewing skills, and there's some resources kind of at the end for supporting conversations about substance use in pregnancy. And again, just general principles for opiates in pregnancy. There's going to be a whole spectrum, and everybody's unique in their situation. Like having an opiate use disorder or being on a medication, doesn't necessarily signal, child protection concerns and all these different things we're talking about. But just other general principles are that detox or medically supervised withdrawal from opiates in pregnancy is not advised. There's increased risks of overdose, death, harms in the pregnancy, very high rates of relapse to opiates for people who are dependent. So we need to make sure, no matter where we work, that we're messaging to people who are pregnant or women that they should continue on opiate agonist therapy or engage in care. Untreated opiate use in pregnancy can increase the risk of placental abruption, preterm birth, overdose, and fetal death. And opiate use, whether it's heroin or hydromorphone or methadone, is not associated with any birth defects. So all women should be offered initiation or encouraged to continue on their medications to manage opiate use in pregnancy. And I would encourage you to know who your local prescribers are or local resources, and ensure that people are connected urgently with care. There should be a reason that they can see a provider in very short order, and considering inpatient versus outpatient for stabilization. So here in Saskatoon, we utilize the prenatal unit at Jim Pattison Hospital if women are needing a little bit more intensive support or stabilization, but most people can be initiated and sort of stabilized in the community as well. And breastfeeding or chest feeding is safe and recommended for women who are prescribed methadone or buprenorphine naloxone. It reduces the severity of neonatal opiate withdrawal, and that's through all the skin to skin, and improves attachment. And again, as providers, we do not have a duty to report substance use in pregnancy to any child protection agency in Saskatchewan, since a fetus is not a child. And this just highlights the report that Dr. Brindamore mentioned. So, sometimes as care providers, our first instinct might be that we need to engage child protection. However, this is very damaging to the relationship with the person that we're caring for, and it might actually drive them away from care and then lead to worse outcomes for mom and infant and family later on. So as we build rapport and trust, some people might want to connect with child and family services in more of a preventative way. And that is an option. We do have a program in Saskatoon called Prenatal Pilot Project, or the Prenatal Program. That program is voluntary and requires the informed consent of the person who's pregnant, but it is another option to help support people and make planning ahead of time.
So now we will move on and talk a little bit about trauma and substance use. So when we think about caring for women who use substances in pregnancy and their newborns as well as their older children, it's critical to frame all care with an understanding of the root causes of the substance use. So the reasons people use drugs in pregnancy are, of course, multifactorial, but one of the most compelling is our focus today. So it is trauma. So of course, not every person with trauma will develop a substance use disorder, and not every person who uses substances has a history of trauma, but there's evidence of a very close association between the two. You might be familiar with a study done in 1998 at Kaiser Permanente that drew a correlation between certain types of severe trauma in childhood and the later risk of developing substance use disorder later in life. So what they studied were physical and sexual abuse, and the presence of drug use, mental health disorders, incarceration, violence against the mother, or an absence of a biological or two parents in a home. So what's interesting, one part that is interesting in this study is that the subjects included were primarily white, middle-class American, 44% of which were college educated. So despite these social advantages, adverse childhood events were strongly associated with increased risks of substance use. So for us, keeping this concept in mind can help us to generate compassion for what many people with substance use have suffered and reinforce the need for empathy in our interactions with them. And something that's important to remember too is that the reason people use drugs is not necessarily because drugs are addictive, but it's a reaction to comfort the distress from trauma of childhood experiences. So the best way to target drug use is not to target the drug, but to target the underlying issue, which oftentimes is trauma. And so if you look more closely at these numbers, we can see that people who've experienced psychological trauma, and especially these adverse childhood events that we were talking about, will also have a dose-response effect. So if you've experienced in your life 1 or more ACE, you're 2 to 4 times more likely to start using alcohol or drugs at a younger age. If you have more than 4, you're 7 times at higher risk of alcohol use in adulthood. And more than 5, that risk increases to 10. And if we look at injection drug use by women, we can see that 78% can be attributed to an adverse childhood event. So we also know that those individuals who have experienced multiple ACEs often follow a trajectory of negative health outcomes throughout their lives. So potentially starting with historical trauma and progressing to functional impairment, adoption of risky behavior, and early death. And that's not only related to mental health, of course. We also know that most measures of health, from diabetes to cancer to infectious diseases, are influenced by social adversity. But the important takeaway here is not to label such individuals as condemned to a specific fate, but to see an opportunity to intervene and change the trajectory by providing support. Sorry, my dog is barking. It should stop soon. But by providing support that assists them to build their own resiliency and capacity. So understanding ACEs will also help society and providers alike to think about how to promote protective factors to counterbalance the known associated risks. So that's how we can see that ACEs are not associated, but predictive of health outcomes later in life. Because we know that there is also protective factors, such as connection to at least one stable adult, supportive community, and opportunity to learn healthy coping strategies. And so we need to consider the foundation of that pyramid, including generation and historical trauma, and the social conditions in which people live, so that we can shape our approach to women who use substances in pregnancy and their infants.
All right, we also just wanted to touch on violence-informed care. So as again, many of you in this audience, I'm sure, are more aware than I am, intimate partner violence is very common throughout Canada. Use of control and power over a current or intimate partner, but also just to name the violence and hate that exists in our Canadian society, especially towards Black, Indigenous, people of color, and trans people. And I think we're all very aware of, some of the more recent stories in the news and in the criminal justice system right now. But also just to highlight again the Reclaiming Power in Place report for missing and murdered Indigenous women and girls in Canada, and just also to name that we do have violence that exists within our health and medical institutions. And even thinking of closer to home, the recent report or external review, tubal ligation in the Saskatoon Health Region, lived experiences of Aboriginal women, by Drs. Boyer and Bartlett, examined the context of forced sterilizations of Aboriginal women in Canada and pointed out the racism that's inherent in our systems. 1 in 5 Canadian women report some kind of abuse from an intimate partner. This risk increased 6-fold for Indigenous women. And in the US, they had data that 85% of violence against Indigenous women was committed by non-Indigenous men. So just trying to understand also the context of violence that women are facing. So what can a trauma-informed approach look like in our practices? So first is safety, and so having a welcoming environment. Even just little things like I try to always thank people when they're coming into the office, and even if they're late or whatever, just like thanking them for coming and knowing that they can always come back no matter what's happened. Last appointment or whatever, addressing immediate needs. So, my goal for the day might be to check a blood pressure and, prescribe a prenatal vitamin or whatever, but what is that person's goals for the day and starting there. Collaborative services. So I think knowing in our communities what the resources are, trying to build relationships with other service providers and having good collaboration that way. For those who work in a labor and birth setting, thinking about how different forms of trauma that, again, we don't need to know someone's specific story, but just understanding that the context of trauma is there and how that could affect their experience of labor, of birth, of our hospital institutions, and recognizing that their reactions are not, are more complex. There's more to it than what the initial situation is. And also the importance of really supporting that immediate attachment. If we know that somebody probably could have a history of trauma, how much more important that initial skin-to-skin and bonding time is. And I remember not too long ago hearing stories about in our hospitals in Saskatoon, social workers or different strangers coming into the room right after birth and wanting to talk to women and asking them very personal questions. And really that's not the time. We need to, regardless of the bigger situation, we need to protect that immediate postpartum time and support attachment, and the other things can be sorted out in time. And always asking permission. And again, I think this is speaking really to medical providers. So when we're going into a room, when we're wanting to examine somebody in labor, when we're offering an intervention, that we're making sure that we're explicitly explaining why and asking permission before we perform any kind of interventions. Harm reduction. So harm reduction is referring to policies, programs, and practices that aim to reduce the negative health and social economic consequences that may ensue from the use of legal or illegal drugs without necessarily reducing drug use. So harm reduction is more than naloxone kits and syringes, although those are essential, but recognizing that we can incorporate harm reduction into our practices. So, another way to think about this is when we're thinking about this whole context, how can we reduce the harm caused by colonization, violence, decades of failed and racist policies, and fractured communities? So, our principles of care, again, for harm reduction in pregnancy, we have a great deal of evidence from programs across Canada as well. So, harm reduction in pregnancy programs have been shown to reduce overdose deaths and morbidity, and that's morbidity for pregnant people as well as their infants, improving nutrition, reducing HIV and hepatitis C perinatal transition, improved newborn outcomes, so reducing preterm births and improved birth weight, improved engagement postpartum in the 4th trimester, reducing alcohol and drug use, even though that wasn't a primary goal of the programs and wasn't a requirement to access programs. They've also been shown to be cost effective and increase the likelihood of mother, baby, or family being discharged from hospital together, which I would argue is one of our most important outcomes to aim for. So we can see that we can incorporate all these different principles into a person-centered approach. And I left an empty bubble there just to recognize that it's not complete and that I'm missing probably some very important things. But essentially, if we can integrate all of these services and supports and practices together, we can engage women in a respectful, empathetic, and collaborative way, and that will improve engagement and therefore outcomes for both the mom and her newborn. So we're just going to quickly look at the relationship between stigma, exercise by health providers, and poor health outcomes. So I'm sure you all are aware of what stigma is. People who are pregnant and use substances are likely the most stigmatized population. And it has been identified as the most significant barrier for women to access care in their pregnancy. There's also a link for this Mothering and Opioids toolkit, which has some really great resources that you can look at if you haven't already. And I just also wanted to include this quote from Dr. Teresa Tam. These many factors of stigma that intersect in complex ways are very much present in our health system and driving those most in need from getting the care and accessing services. It means that we as health system leaders and practitioners are contributing to negative health outcomes. And I thought that's a really important quote because, of course, nobody in healthcare or in any service agency is trying to increase negative health outcomes. But if we can understand and deconstruct stigma and racism in our systems, we will improve outcomes for people. Women need to feel comfortable in seeking support and treatment. So our messaging must not be stigmatizing and should instead be compassionate, strength-based, trauma-informed, and harm reduction oriented. Let's skip past this one and pass it back to Dr. Brindham.
So now we will get in the thick of clinical material a little bit more. So when we talk about NOWs, it's really defined by the dysfunction rather than the need for pharmacotherapy or other treatment. So it's really a symptom-based diagnosis. And it can involve dysfunction in 4 domains. You don't need to have 4 domains to have a diagnosis. But it can include control and attention. So babies will have, for example, short sleep-wake cycles or fragmented sleep, and generally trouble falling asleep. It can involve motor and tone control. So you'll often see babies being jittery or have increased in tone. You'll see difficulties with sensory integration. So they'll be very irritable. They'll be crying with very little stimuli. They'll have difficulty organizing their feeding. They can have GI upset troubles. And we can also see dysfunction in the autonomic functioning. So that's when you'll see sneezing, yawning, sweating. Some babies can have fevers also. So the onset of the symptoms will vary on the type of exposure. So that can start in the first 24 hours with, for example, heroin, to after 5 days when it comes to methadone. And so all of this together can lead to an infant who will have trouble feeding, growing, and generally organizing. And so if it's left unchecked, it can also have severe complications like seizures and even death. And of course, and that's one that's very important for me, is that even a very mild dysfunction can be very distressing for caregivers, especially when there's very little support that's available for families. And so routinely, NOWs will be looked at in hospital. Newborns are observed in hospital for longer after birth if we know that they were exposed to opioids. So we like to aim for 3 to 5 days, after which the at-risk period is a little less critical. And then we use something called the Finnegan scale, or modified, which I'll talk a little bit in the next scale. And there is focus that's given to non-pharmaceutical interventions, but those are hard to implement in busy, stimulating hospital settings. And so the treatment for NOWs is often initiated and completed in inpatient. Although there are some studies that are looking at home-based weaning, this is still rarely used. And so traditionally, or in most hospitals across Canada, this is a tool that we use that looks something like that. So that's the Finnegan modified scale that's used by the Canadian Pediatric Society, and that's still widely used across Canada, including in Saskatchewan Hospital. So newborns get a score. If they get more than 8, we consider treatment. And then we base our treatment and our weaning based on those scores. So at Sanctum 1.5, we although I wasn't involved in the beginning, but we're using a different approach. So you probably know now that Sanctum 1.5 is a 10-bed prenatal care home which supports high-risk and HIV-positive pregnant women who are at risk of having their infants apprehended at birth. So it offers a holistic care environment for mother and their babies who can come and live there at any point during their pregnancy, so either before they get their baby or after they deliver. It's collaborative, of course, and multiple partners are necessary to make this work. And we use wraparound services while trying to maximize independence and control for the women who live there. So all in all, it's aiming to keep mothers and babies together in healthy ways, decrease HIV transmission, and also decrease the number of apprehensions that we see in the 30 days following birth. And so one of the approach that we use at Sanctum 1.5 is using a different scale than the more traditional Finnegan scale, which is called Eat, Sleep, Console. It has a beautiful name, and it really looks at what babies are supposed to do. They're really not supposed to do much else other than eating, sleeping, and consoling. And so the principles of the ESC approach is to aim to support the newborn exposed to substances to achieve these developmentally normal things like eating, sleeping, and consoling. And so we consider the mother or the primary caregiver as the main provider of responsive and newborn-centered care. And we also encourage the mother and the caregiver to consider other reasons as to why their babies might not be eating, sleeping, and consoling, and reasons that might be other than withdrawal. So the scale that is used is very simple, and you can look at it there. And it was developed in 2017 in Boston, and slowly we see some centers in BC that are using it, and we're using it at Sanctum 1.5, so it's slowly taking shape in Canada. So it aligns with the trauma-informed and culturally safe care that Dr. Gardner was outlining, and it promotes mother and baby togetherness. And one of the first interventions that we try to do, other than pharmaceutical treatment, is that we put focus on non-pharmaceutical interventions. So if a newborn is scoring in that graph, then we consider first things like soothers, dark, quiet environment, swaddling, skin to skin, and generally low stimulation to avoid the development of withdrawal. It's been studied and it's been shown to have high inter-user variability, and it can be used by non-medically trained staff. It's low cost, it's simple, and the training for it is easy. So of course, providers may look at other symptoms of withdrawal when they decide to give pharmaceutical interventions or not, but really it looks at what is important: sleeping, eating, consoling. When an infant does all of this, generally it means that they're doing quite well. And so we've looked at our data in Sanctum 1.5 since we opened 2 years ago. And so I was checking with the program coordinator yesterday, and then since its opening in 2018, there's 45 moms that have been through the program and 44 babies, and that's counting the current number of residents. And so one thing that we wanted to know or assess was how NOWS was treated and managed within the program as one measure of our success. And so we're doing a small study that's still not published, but we compared the babies who were admitted to Sanctum 1.5 and monitored with the ESC to the babies who were managed in a hospital with routine care during the same period. So we looked at babies up until from the opening of Sanctum 1.5 until January 2020. And what we found was that the morphine replacement therapy in the babies who needed pharmaceutical replacement peaked quicker and was weaned sooner and faster in the 1.5 group compared to the routine care group. So that led to a total number of days on morphine that was shorter, so 22.5 days compared to 47.5 days in the routine care group. And so, unsurprisingly, when you think about this, the total dose of morphine that the babies in the 1.5 group was also smaller. So we're looking at 21 grams compared to 57 grams in total. So more than 2.5 times more in the routine care group. So it's a small study with low numbers, but it certainly gives us encouraging results, if only to show that the approach at 1.5 is at least equivalent, if not better, than the routine standard care approach. And there's lots of ongoing research that's happening within the Sanctum care group, notably looking at the experiences of women in the program. And so we have great hopes for this ESC program and for expansion of the Sanctum 1.5 model. We're looking at implementing the Eat, Sleep, Console approach within all of the hospitals in the province based on some of the data that we've accumulated at 1.5. And that's probably going to happen within the next 6 months, starting with the Children's Hospital and the Neonatal Intensive Care Unit here in Saskatoon, and then expanding to the rest of the province. I also know that Sanctum 1.5 and the Sanctum Care Group is looking at expanding the 1.5 program to other cities like PA and Regina, because of course we need to make the Sanctum 1.5 benefits available to more women. And hopefully this will lead to less stigma and more support and more awareness across board, and ultimately better health outcomes for women and their babies overall. So as Dr. Gardner mentioned, we have a few resources that we put together. Hopefully those will be recorded and you can watch them later. In terms of Women Together Conquering Stigma, the Mothering and Opioid Toolkits, as well as the Perinatal Substance Use Online modules that are all free resources online. And this is another one that you can look at. And then I'll give the mic back to Dr. Garner for the final words.
All right, we just thought we would end with something that is from that Opioids in Pregnancy Toolkit. And it was the 10 things that pregnant and parenting women who use substances want practitioners to know. Mothers want to succeed. Don't assume we're not trying or that we chose the challenges we face. Language matters. Say things like, I've seen this help others. Maybe this will work. Not, you should do this or that. Show empathy, not pity. Show more compassion and less condescension. Be a support, get behind us. Listen, be curious about what might work for each of us. Be educated. There are a lot of things that play into addiction. Just because you're using does not mean you're a bad mother. Not everyone takes the same path to recovery. Listen to where each woman is at in her journey and what will work for her. Don't judge, instead care. And we just have some references listed at the end, but I will perhaps leave it at that. And hopefully we can have some time for questions.
You can all put your questions in the chat. Just want to comment on Caitlin's comment on is there support given to women who are HIV positive to breastfeed? And Kaylee is right that we generally advise formula feeding, but there is more and more evidence that in Canada specifically, the risk with breastfeeding is very, very low, especially for women who were well controlled during their pregnancy with undetectable viral load. So I have seen, a risk and benefit discussion with the mothers around breastfeeding, and it's really a shared decision. And I think in the future we'll be encouraged more and more with, as Dr. Gardner said, really close follow-up with bioobstetrics and pediatric infectious disease.
I think there's been some questions in the chat box. If Dr. Gartner can maybe read out and respond to some of them.
Sure. So I did see one question asking is Sanctum 1.5 in any Saskatchewan cities? So Sanctum 1.5 is located in Saskatoon. Hopefully one day there could be Sanctum 1.5 type programs throughout Saskatchewan, but right now it's physically in Saskatoon. It does accept referrals from anywhere in Saskatchewan, and so yes, it would mean that unfortunately, if women are from other communities and are needing the Sanctum 1.5 supports, that they have moved to Saskatoon and stayed at Sanctum 1.5 during their pregnancy and postpartum, and then usually a plan's been made to help them move back closer to their communities. But I agree, like ideally we could have a system that would support people to stay connected to their communities and families and bring the supports to them. And a question about how long women stay at Sanctum. They can be referred anytime in their pregnancy, and so theoretically they could be referred really early and stay there throughout their whole pregnancy, and then usually up to 3 months postpartum is when they physically stay there. But again, everybody's individual and unique, and so some might end up staying a little bit longer, a little bit shorter. And then the other part of Sanctum is that they have transition supports, so that after the 3 months there, they transition to whatever kind of apartment or housing situation, and they stay connected with the program through their outreach. But I should let Dr.
Yes, I agree. So there's follow-up afterwards, and then depending on the woman and the family's needs, they can be either in the independent housing or in supported housing, or some will move on to stay with family. So it's really individualized care, and then the team at 1.5 will continue to follow after they are discharged and provide support. And then I also saw a question from Brenda asking if they take other moms besides HIV positive, and that's correct. So anybody who is high risk for any reason or who has had involvement with the child protection agencies or has kids in the foster care system or has housing difficulties can be referred to the program. There's a question from Jocelyn asking about the role that midwives are playing in harm reduction, because they do work in priority populations and have pregnant people who have a history of opioid use. Dr. Gardner is more the one that deals with pregnant people, so I might let her answer this more completely. But I have seen beautiful programs in many provinces where midwives are playing active roles in harm reduction for sure, but Kaylee might know more than I do.
Anything else there? Yeah, that's I think a great question. I think that harm reduction aligns really well with what I understand the principles of midwifery to be. I'm not an expert in midwifery, of course. I was fortunate to work with an interdisciplinary program in Vancouver, the Surrey Community Birth Program, which was family doctors and nurse practitioners and midwives working and doulas working together. So I think that I guess I think all the same principles apply to all of us, regardless of what our role is specifically. But yeah, I guess I'm not sure if Jocelyn, if you are a midwife, maybe you have some more specific resources to share or ideas to share. That would be wonderful.
All right, thank you, Dr. Gardner and Dr. Brinamer, for a fantastic presentation. It's really been a great session. I'm not sure we have any more questions, or do we have any more? I don't see anybody typing. Once again, we apologize for the late start, but I guess we're still kind of on track, just a few minutes behind schedule. In the chat box, I have my email address. If you want any information regarding this presentation or anything related to perinatal and infant health, please feel free to reach me. And I can also pass on your information to Dr. Gardner or Dr. Brinamer if you want to connect with them. Also, we have this short evaluation for this webinar. I put the link in the chat box, and you also get a link once this meeting ends. Please go ahead and please provide your feedback. With this, we've come to the end of today's webinar session. Thanks so much for attending. The link to the recording will be posted on our website a week from now. By this time next week, it should be up on our website, but I'll send out a link to everyone as well. So you can also refer to it if you want to take some notes or you're interested in some of the slides. Thank you so much for your attendance today, and do have a lovely afternoon.